Hello, everyone. I'm Doug Cushman, the president of the Case Management Society of New England, and I'd like to thank you for joining us for this presentation, Balancing External Factors and Ethical Case Management. I'd like to thank Vitra Health for sponsoring our program this evening and introduce Ann O'Connor, the clinical director from Vitra, who will tell you about their company and introduce our speaker.
Hi, welcome everybody. It's really nice to be here. It's great to be able to do this. I am a nurse. I'm the clinical director at Vitra Health, and I've been a nurse for over 40 years. I've done ICU, home care, hospice, adult day health, and now Vitra Health, where I get to do a little bit of everything, which is awesome. Vitra Health's mission is to improve the accessibility and the quality of healthcare to our clients. We do that by providing community-based programs to maintain clients in the community safely. We have the group adult foster care program, adult foster care, adult day health, and we have a VNA also. So what we like to do is assist families with education, medication management, assessments, coordinating appropriate referrals for mental health, DME, and making sure people get to their physicians. So we do a lot of case management and a lot of nursing. We do both medical through the VNA and then non-medical through our other programs. Our programs are mostly ADL and IADL based, so we have to go in and do the MDS and assess our clients for the level of care that they may need, and then we assist them with getting that care. Programs are client-centered, and we do a pretty good job at including everybody in the plan of care. So it's a great way to help people stay in the community for as long as possible. It keeps people from ending up in assisted living or long-term care before they're ready. And it gives people an option to stay in the community with the assistance of a case manager or a nurse. So that's who we are, and I would really like to introduce you to Sandra Lowery, RN, BSN, CCM, CNLCP. She is the president of CCMI Associates, an independent case management firm. Sandy has worked as a case manager, a case management consultant, and a trainer for the past 32 years, working locally and nationally for both payers and providers. She has served as a defense expert on legal cases involving case managers. Sandy is on the editorial board of Professional Case Management. In 1995, she was the recipient of CMSA's Case Manager of the Year Award, and in 1996 received the Case Manager of the Year Award from CMSNE. Sandy was on the CMSA board for 9 years and was the 2000-2001 president. She is the founder and the past president of CMSNE. Welcome, Sandy.
Thank you, Ann. And hello, everybody, Zoomers out there. You're probably a lot more familiar with this than I am. This is my first Zoom training, totally Zoom. So we'll see how this goes. As Ann said, I have been doing this for a very, very long time. Obviously, I love case management, and it's been quite a journey, quite an adventure, and I have learned a lot. And I'm hoping to share some of what I've learned with you, not only just in principles and things, but also my experience and experience of others to try to bring out some case scenarios or examples to help bring out some points. So, come on, slides. They're not going on me. Okay, let's see why my slides aren't going. Okay, these are our objectives. Look at, again, the biggest really objective here is to talk about, in the midst of everything, when you're feeling this ethical dilemma, you're not feeling comfortable exactly which way to go, there can be a host of external factors that are playing out for you. And we're going to talk about those. Sometimes it's helpful to know what's going on as you try to move forward in making good moral decisions. We're going to share some resources at the end of this for you, and really talk about why are we getting such an emphasis on ethics in case management in recent years. What's that all about? Okay, well, I was going to start in 1996, and CMSA, Case Management Society of America, did identify that case management was challenged ethically. The case managers are facing ethical dilemmas frequently, and decided to help with that by developing basically a framework of principles. Most of you are probably familiar with those. We'll briefly go over those as well. But it really was the first time that we really said, there's something we need to do about ethics in case management. Now, just a year later in 1997, I didn't know that the Wall Street Journal even know who we were, but apparently in 1997 they did, and said, oh, you poor case managers, you try to do the best thing. It's a constant struggle, and boy, isn't that true. So we had some recognition by the media, but really it was kind of a quiet period after that until we leapfrogged into 2014. And really this is kind of our point where we really had an emphasis. How that happened was basically out of the CCM Commission's 2014 survey. I don't know if you're familiar with them, but they do a survey of the field every 5 years, so they can basically update the certification exam and try to keep current. And that's what happened in this case. The 14 survey was done. They looked at this and they said, whoa, there are 2 areas that have really jumped up in importance for our practice. And one is in ethics and the other is in quality on outcomes. And so this is kind of, all of a sudden we have this in the spotlight that, whoa, okay, this is important enough for us to even spend more time on exploring. And in fact, you may well know this, that they even carved out a specific number of CEs in ethics to be able to be eligible for renewal. That was a real statement, that out of the 80 contact hours every 5 years, that 8 of those had to be specific in ethics. Maybe why some of you are watching this presentation. But it really was a big statement, and it really made us stand up and go, whoa. Now, shortly thereafter, American Nurses Association said, in 2015, you know what, we need to come up with our code of ethics too for nurses. So they wouldn't. And then a year later, the National Association of Social Work came up with a code of ethics. And I've given you links if you're interested in exploring these. Now, speaking of the CCMCs, the surveys, they also have and have had for years a code of professional conduct, how you should conduct yourself ethically as a case manager. And then in 2017, they decided to update those standards, and those are, there's a website here if you want to look at those as well. The CCMC, again, the CCM Commission is the case manager's only organization that does allow the public to have recourse for any kinds of misconduct, any allegations of misconduct based upon their standards. And they have had allegations filed for misconduct of case managers, and have actually had case managers on remediation programs. So it is really the only organization that polices case managers and has that public recourse. If you're not familiar with this, you may want to look at this link and look at that complaint form to see what it looks like. Now, what is ethics? I mean, we all kind of think of what it is. I mean, this is kind of some formal language here that really is looking into what is moral and give us a rational ground for making those moral judgments. Now, this is getting back to CMSA's ethical principles, probably very familiar to you, that we have the duty to help someone be as autonomous with self-care, self-management, and facilitate voluntary informed decisions. We have to try to help people be healthier, beneficence, do no harm, non-maleficence, to tell the truth and be fair to everyone. And you say, well, this makes so much sense, but as you practice, these concepts can be a bit challenging. So when we took, now a major focus of this presentation is on this. And what are those influences that cause us to pause, to really say, what's going on here? Why am I not feeling okay about this? And these are the different, look at all the different influences, your providers, your payers, your clients, we know that, your professional discipline and your professional case management standards, society, legal and legislative factors, and you all work for somebody else, your employers, and how they influence you. And more recently on this list, we've added social media, which is going to be getting more interesting. And then of all this, you have your own personal values you bring to the scenario. So we're going to kind of go into all these different factors a little bit more. We know our providers took the Hippocratic Oath or whatever their discipline is to say our job is to help some people get healthier. And we do that. Historically, though, it was easier because you just took care of people the best way you could. And the basis for a lot of your moral decisions were your own values. You didn't have a lot of those external factors that we have in recent years. Now, this is one that probably won't surprise some of you. Doctors want to take care of patients and they want to help them get the reimbursement they need for the care, and they can be influenced to do what we sometimes call creative documentation. And that can vary how you might perceive that, because let's take the scenario of this guy. He was obese and wanted to have bariatric surgery. Goes to the physician who decided to document, not accurately, but document that he had tried all the exercise and diet regimens and therefore needs bariatric surgery. Now, this guy had not done any of that. So is that fraud? Is that fudging the truth? Now, let's take another example, though, that a gentleman came to the physician and said, oh my word, I've been on a disability and I really want to stay out longer. My autistic child is not doing well, has to be home and have more one-on-one care, and I really don't want to have to go back to work. So the physician kept the gentleman out longer on disability. Back to how you perceive this, where the ethics are. Okay, then we have some folks that believe that even small gifts will influence someone in their decisions and their behavior. So, you know, we're case managers. I mean, now I go places and I say, no, we can't even accept coffee from a vendor. I'm like, really? No, we can't have lunches either. I'm really, we're not wealthy. We used to get free lunches. It was wonderful. But now it's like, because of this concept or this philosophy that it could possibly cause us to consider reciprocity, that may be a bias and reducing some influence. Okay, now we're going to start with a little more in-depth, digging a little deeper here with our provider community. Again, the old world of just providing a service, getting paid for it, has changed immensely. And we have what we call value-based purchasing, pay for performance, which has various kinds of financial and quality incentives and disincentives, and basically created report cards for accountability instead of just saying we're going to pay you for a service we want you to be performing. So giving several examples, perhaps you've explored these yourselves. Very common today across the country are the payments for a joint replacement, hips and knees, paid in what we call a bundled payment method, meaning that orthopedist gets one fee for the procedure and the recovery period to a certain time frame. And therefore, in essence, the orthopedist becomes the insurer for that procedure and recovery. And therefore, they make the decisions because it's their money. within some parameters. But so those of you who may have worked with or for a skilled nursing facility in recent times may have noticed a significant decrease in admissions for rehab after a joint replacement, because a huge percentage of them now are going home. Now that can be good, right? And it just depends. I can give an example. This guy was 85 years old and lived alone, had a hip replacement, and was in a bundled payment scenario with his orthopedist. He had the surgery, and the physician referred him to home, where he ordered some home care, PT, but not a home health aide, because he said, no, he won't need that, and not a bedside commode, because he said he never goes to the bathroom in the middle of the night. Now, when it's their money, you have to look at, is this, as a case manager, of course, is it safe? Is it going to produce, healing and safety and so forth? And if you're working with that orthopedist, you're hoping you have the same values and shared thoughts about what should be done in the best interests of that patient. Now, I did have one family that had told their loved one that had joint replacement that they thought that he was going to go to a skilled nursing facility for rehab, that rehab was what was needed, because they get more physical therapy. They get daily physical therapy in the skilled nursing facility versus at home. And, it was like, what did she think about that? And of course, that's when you do your case management, and you're ethically in a difficult position, because you're working with the orthopedist who is, prescribing one thing and getting these questions. And of course, what I said was, why don't you call the home care agency and see how often they will do PT, and make your own informed decisions here. But they do have the right, in terms, that they will meet the level of care criteria for skilled. Do you educate them about that? Let's talk about the physician who's discharging difficult patients. This is really happening frequently, because certain difficult patients are not adhering to being healthier, setting goals, and therefore affecting negatively their report cards. So they're giving them 30-day notices of termination of services, and they will no longer be treating them. And I often say to case managers, and where will they go? And there will be the ones we will be seeing somewhere. And of course, our job is try to help work with that physician to see what are the adherence factors and what can we do about that. But ethically, it becomes a challenge. Well, okay, how about the provider's influence on a client's decisions as well as requests? Now, we had one woman who came in and said, I want this brand name medication. I don't want to go through all these different trials of different generics. I just want to get right to the gold standard, because that's what I was told by my family that I was going to need. It would help me the most, and that's what I want. And of course, the physician said, well, for reimbursement, she said, I don't care about reimbursement. What if I pay out of pocket? Which she was willing to do. So the physician then was in a could prescribe it, right? The problem with that is he knows, or she knows, about her report card. And one of the criteria is how many brand name medications were prescribed in the last year. So there is kind of a dilemma which way to go. The next example, and this is really controversial, there are a lot of ACOs, especially in New England, accountable care organizations that have case managers working with them, which is good. And then, of course, an ACO is a network, basically an affiliated network to provide a continuum of care, that if they meet certain quality measures and cost-effective measures and so forth, they, at the end of the day, at a certain time period, will be able to share the savings of any financial savings they created through having this network. And that's the design of it. The challenge is a couple of them. there are case managers working in ACOs with clients who do not know what an ACO is, nor that they are in one. I had one ACO in one of my classes, and she said, I am told to direct care to the providers in the ACO. I am told I am not to give them choices. And you all know about your standards of practice and what a difficult position that put her in. So there are some good parts and bad parts to the different kinds of networks, but we do have to adhere to our standards of practice, and sometimes that can work against where we work. Now let's talk about the conflict of interest. We see it, and don't we? Now, how about the practitioner who owns for example, in this case, the durable medical equipment company. And all those with good insurance were referred to that DME company, and those that did not have good insurance, so to speak, good benefits, were referred to other medical equipment companies. Now, if you worked with that physician, would you report that as a conflict of interest? Or would you inform your clients that, did you know the physician owns this firm? That comes to help them make their decisions. Now, a lot of case managers today work in what I think is a wonderful environment, which is in a primary care practice, a clinic or a practice. And in essence, the PCP is their employer, their supervisor. Sometimes they're hired by the PCP directly, and sometimes they're what we call embedded or hired and placed by a third-party insurer to be in that PCP practice as a case manager, working together with the PCP to, again, help people get healthier, more independent, and so forth. Now, that's wonderful, as long as the case manager and the physician have similar values and aligned goals. I think where it comes problematic ethically is when those don't line up. And I think of the kinds of examples of that are related to end-of-life decisions, whether their views on physician-assisted death, treatment withdrawal, abortion, and so forth. As long as they're together, that works, but if not, it can be very challenging for ethics. Now, payers have their own challenges. There is no finite definition of what is medically necessary. We know that's kind of the general language that determines access to a benefit. And there are some resources out there that have their own definitions of things, but there's not like a national guru or one resource that this is it. So you'll have different interpretations. Big one, a huge one in our country is a shower chair, is a shower medically necessary, or is it okay just to be bathed in bed or sponge bathed? What is more, of course, one side's going to say one is more hygienic and more dignity, it's more psychologically beneficial, and maybe skin is better, but the other says, no, what's wrong with just bathing in bed? So you have those kinds of things. And if you're in the position in doing UM and making decisions, what is medically necessary, you can see how there are two different opinions here. Now, some insurers, I've worked with a lot of health insurers and others for that matter, and who will not be willing to consider cost benefit scenarios for exceptions. Now, there are many that do, and to me, that's one of the best tools in our tool chest. If we can come up with a win-win scenario, because you all know, benefits just don't meet in a neat little package all the time. They don't just fit in that little box. So there are those that are certainly out of the normal kind of benefit structure. So if we can come up with something to say, well, if you covered this, it would be a win-win for you and also for your insured. The example I have here was actually one of mine with a gentleman who had a spinal cord injury, rendered quadriplegic, wanted to go to a specialty rehab hospital. He did. It was a network hospital. And had some medical complications when he was admitted. So the specialty rehab hospital said, well, we can transition you across town to another network acute care hospital who can do your medical care. And once you're cleared by them, you can come back to us and we'll start your rehabilitation. He only had, how many had? I think it was 60 days or something, 60 days of a rehab hospital benefit. And he and the rehab hospital wanted to preserve those benefits for the best use of them, of course, with rehab versus acute care. But the rehab hospital said, wait a minute, we're licensed as an acute care hospital. We can do the same medical procedures that an acute care hospital across town could do. Why not just stay here? Well, the short answer to this is the insurer said, no, even though it's going to be costlier for them to transition him to my ambulance back and forth, to go a whole new treatment team to get to know him, it's going to take longer. They did not feel that was medically necessary, and therefore, if he stayed in the rehab hospital, it would count towards his 60 days, even if not one PT, one OT, or any other rehab services were provided. So that was one where they just were not willing to consider that cost benefit exception, even though it was a win-win. Now, we have a problem with low reimbursement rates. I'm sure some of you have experienced this, which have decreased access. There are some specialists that will not accept certain rates. To my surprise and angst, actually, I learned recently that in my community, I'm in the Prescott, Arizona area, and in my community, we have one GI doc who will do colonoscopies under Medicare because the rates are so low. And I just learned a month ago that my gynecologist that I've been seeing for women's health for 4 years just announced that they are no longer accepting Medicare. Now, I'm not talking Medicaid in either of these cases, Medicare. And I'm sitting hearing people say to me, I can't wait till I get Medicare. And I'm like, really? I don't know. So it's those low reimbursement rates can, even if they have the benefit, can decrease access. Now, we already know restricted networks can decrease access, actually by design. That's design of the benefit package to do that so that they can save money and it will cost less. I will share with you one example of that. A friend of mine in New Hampshire has one of the Obamacare plans, and she has a $7,000 deductible and some copays on top of that, and she can only treat in New Hampshire. She can't go to Massachusetts, she can't go out of state unless the providers in the network agree that they can't provide it. Well, she has a husband who has a very complicated eye problem, wants to go to Mass Eye and Ear. She have to get an ophthalmologist in New Hampshire to say, we can't do that. And so your networks can really be a challenge in trying to access as well. Now, there are many case managers who work in an insurance environment that has a claims manager that they report to, that basically is their supervisor. They decide if and when a case manager is going to be on a case, how long, and so forth, and they are the decision maker for benefits. Now, that can get challenging if the claims manager doesn't see the client's needs in the same way the case manager is advocating for. And I've given you one example. It was one of mine a few years ago now. This was a gentleman, he had workers' comp insurance, younger man, he's in his 40s, I consider that very young now, and he had been home very disabled, needed help with mobility and everything, and he really wanted to stay home, and he had home health aid assistance. Unfortunately, his workers' comp claims manager started decreasing the aid hours, and he was getting less care and didn't understand why, and I didn't either until I asked. And basically the claims manager said, I really want him in a skilled nursing facility. And this is my way of kind of nudging him in that direction. Now, this is a guy in his 40s who did not want to be in a skilled nursing facility. I certainly didn't either, just because he wanted to be home and he was getting good care from the aides. But that's the claims manager's decision. And we do our best to advocate and explain why this might be better and why this is why they want it, but that's their decision. And then we already touched on the Medicare auto-assigning, oh, did we? Actually, this is, I don't think I did, I talked about ACOs, but I learned myself. And I'll give you an example. When I was with my GYN, the office called me and started asking me about whether I had a hemoglobin A1C test. And I thought, what? I go to them for women's health. I filled out that wonderful form you fill out about your medical history that had no diabetes, no, actually I don't have any chronic diseases. And why is a gynecologist's office asking me about a hemoglobin A1C level for diabetes? So I asked them, why are you asking me this? Is there something in my record? Oh, no. Medicare wants us to do this. Medicare, I'm on regular Medicare. So I thought, what's this? Am I in an ACO? Because that would be the kind of question that an ACO would want to know to meet their measures. So called out Medicare, and actually they told me, they said, oh yeah, you're in an ACO. And I said, really? You didn't tell me this. You didn't even tell me what it was. And I didn't give you permission to go around getting information about me. And she said, well, you can opt out. I said, well, how do people opt out if they don't know they're in it and they're giving permission to be in it? So we have some challenging things going on. I understand they're going to try to work on that issue. That's my understanding, that this year they might work on that. Now, we know our clients do present with many, many challenges for us. And you know those clients, right? They get on the internet and they get volumes of information. And it's like this, and they're gonna go take it to their provider. And you're like, oh my word. Okay, let's talk about a good way to do this. First of all, what are good research sites? What's the difference between anecdotal information and research information and so forth? And then what's a good way to get that information across to a provider who has limited time? You know, how's a succinct, appropriate way of communicating this? But it can be challenging, and there's a lot of information out there, as you know. Now, we all have our clients that present with behavioral challenges, and it's not easy to be objective. I often tell case managers, you know what, if you really are having a challenge with this difficult behavior and unable to be objective, you really aren't doing a service to your client, and you need to work that through and trade with somebody else or find another way through it, because you really won't be very effective if you can't be objective. Oh, we all have our personal ethics, and then our clients have their ethics. So hopefully they line up. I'm going to share with you an example that some of you may have heard me use in other trainings, but it's one that I'll never forget. It was a friend of mine, and she was a nurse case manager working with a home care agency. And she went to see her client who had later stage lung cancer, and said, you know, my wife is really struggling with this, and could you go and just go and maybe have a cup of tea with her and just give her some support? So she does. She goes in the kitchen, and while they're drinking tea, bang, he shoots himself in the head. Now, she has very significant values related to religion, related to suicide and taking one's life. So she really struggled with, did she aid and abet this? She also struggled with the fact that, did she abandon her client by going in the other room and therefore, you know, not aiding and abetting again. So there's no easy answers to these. You hope it doesn't happen to you, but it can, and you have to try to work these through. Now, all of us, I can't imagine there isn't anyone out there that's not dealt with someone who is making an unsafe decision. And at least as we see it, and we're of course trying to promote their safety and their wellness. And we also have to help them with autonomy. And there's where the challenge gets. The example, this actually was a gentleman who was in a court case. And this was a gentleman who had been in the hospital for the 4th time or whatever with substance abuse and recovered, was ready to go home. Physician cleared him for transition. The case manager, it was a team, social work nurse team, was working with him and trying to make informed decisions. His family did not want him to go home. They said he has no heat. This is in a very cold state. No heat, no electricity, no water, and a broken wood stove. And we don't want him to go home. It is not safe. But he has now been cleared cognitively and said, I want to go home and I have the right to go home. And so they helped with resources, but they did transition him home because of autonomy. He had the right to make that decision. Unfortunately, he did die that night in a home fire. So, you know, did he make the informed decision? Did they have the resources and fulfill? I will tell you, this did go to court. I was involved, and the case managers were cleared. They were not found to be negligent because they did do their duty. Now we have aggressive care that sometimes you wonder, oh my word, is this going to be futile? And the problem is, as you know, a lot of treatment is not a science, especially in cancer. We have statistics and they're great, but it's not an exact science. So the person's getting 4th-line chemotherapy, is that really appropriate? Or then I think of my 90-year-old neighbor who walks 2 miles a day and had 7 years ago had been diagnosed with metastatic bladder cancer, no symptoms today, and walks 2 miles a day. So yikes, you know, how do you figure that one? How do you work that through? And our wonderful US Army has done a great job for our injured soldiers and airmen and so forth with all these new treatments and equipment and prostheses, and they're wonderful and they're very costly. And so at what point are these devices and these treatments going to be for convenience and comfort back to, or are they medically necessary? And that is a tough one to grapple with. And of course, the insurers will say we can, if we start paying for these $50,000 prostheses and ever, we have to increase the insurance premium. So it comes around back to those who pay for the insurance, and they're right. So it's really hard to say what's right here, and so forth. You all work with families, and there's 5 people in that family, and not one of them will lift a finger to help someone. And then there's oh my goodness, this man is home with the tracheostomy, lives with his elderly mother, and she gets up several times a night to suction him. Now, how do you judge one family from another? It's really hard. Speaking of families, how about their influence on their clients' decisions, on your clients' decisions? Those are, I don't want to go down the road because there's so many different examples of that, but we know those that heavily influence them, not necessarily in a way that's going to be healthy, but it's their support system. Those of you who work with adolescents, I give you hats off, kudos. They're hard enough when they're our own, but when they have health challenges, it just adds another layer of complexity. And the parents are really often affected so much by this, and they're trying to make decisions for their child, their adolescent, and they don't always agree, which beings really a problem. Or what can happen, and it does, the adolescent reaches the age of maturity in that state, and that varies across the country from 14 to 18. Once they reach that age where they can make the treatment decisions, then it gets even another layer here, because what if it, again, is something the parents would not have wanted? I can think of the adolescent who said, Dad, I know you want me to get more chemotherapy. I'm sick. I'm tired of vomiting. I don't want any more. And I'm now at an age where I can make that decision. Or Mom, I know you don't believe in blood transfusions, but I'm tired, I'm weak, I'm now of age, I want the blood. And that just puts that family in a terrible position. But it happens. And it's even more complicated if we have what we call binary family, meaning there are two parents involved that are typically going to be separated or divorced. They usually have joint custody, so they have to come together to make a decision, and they may have another agenda going on. And it makes it very difficult to come together and make a decision and agree. Okay, well, we all have organizational policies and procedures. So if you work for an organization where you are doing both case management and UM, then you are giving mixed messages and you have dual roles. And that's not to say you can't do them, but it does give two challenges in terms of the roles that you're playing. One is you are a gate opener as a case manager, right? My job is try to open up to resources, to access them, and I call myself basically a gate opener. On the other hand, I'm a gatekeeper because I'm the decision maker to accessing service reimbursement. The other dual decision scenario is my job is to help you make informed decisions, help you be the decision maker based upon information and so forth. But, I'm the decision maker when it comes to benefits. So there's where that gets a little problematic in keeping role clarity and, and trying to work that through with dual roles. Now, the case manager, I hope we don't see this anymore. We had a lawsuit that may have taken care of this, I don't know. But there have been some case management organizations where the case manager's performance is based upon the savings. So if they get somebody out of the hospital earlier, they help someone get home versus a skilled nursing facility, which is more expensive. Did they save money and therefore they met their performance expectations? That gets a bit challenging if that's the case scenario for case managers. We are moving very quickly in our country towards supporting and facilitating evidence-based treatment guidelines. Now that's wonderful if it meets with your client's values and their wishes and so forth. So I think of several times where that may not be the case. Let's talk about the guideline, the evidence-based care guideline, with what's the criteria for discharge. We have different companies that do this, and they're just going to use one as an example. This person was in the hospital and did meet the evidence-based care guideline for transition from an acute care setting. However, he told the case manager, I really don't want to go home. I really don't want to go home because if I do, my wife is going to have to quit her job to take care of me and we won't have an income. So the poor case manager is in this dilemma of, okay, you meet the criteria, but. So that was another challenge. I hear almost every day, how can I do my job with the workload and caseload that I have? And there's no easy answer to that because caseload it varies by where you work and how you work and so forth. So that is something that is definitely been, I wish we had some benchmarks for that. I know there have been attempts at that, but it's very hard to line up apples and apples to get good benchmarks for that. Yeah, and one of those factors in caseload and workload is really the training. How they have the training, excuse me, the training for the role that they've been asked to do. And there are several I've talked to. I could be so much better at my job if I really knew more about what I do and how I should perform rather than just understanding the computer and, the basics. Speaking of other requirements, documentation systems. I've seen, I'm sure you have too, 5, 6 systems that you're supposed to go in and out of, and it's very difficult to be efficient and get to your job. To be able to to check in on your client, to be able to find out how they're doing, to contact the provider, to get an update, that kind of thing. When you're still just trying to figure out where to put this information or where to answer this or put in the data you need to put in and so forth. Now, we have a standard of practice that says a client must consent to case management services. Well, how do you help somebody who doesn't want you to help them? But there are some organizations that hire case managers who basically assign clients to case management, and their policy is that the client can opt out. So is that implied consent? Does that meet the standard of practice? Or, and does it meet the standard of autonomy and informed decisions? Now, again, we are cost quality advocates. We try to help both those cost and quality outcomes, and it depends where you work. What are your performance metrics? Are they both quantitative and qualitative to capture what you're doing, or just one or the other? And I've seen it all over the map where that is. Now, the nursing licensure, I hoping is not an issue anymore. It's certainly been out for a while now. Whereas the Board of Nursing in every state will determine will determine that a nurse has to be licensed in that state to practice, in this case management, but to practice their nursing specialty. And that if this relates to people who work out of state. Hopefully this isn't but it can. I had a case, I don't know, I've had 2 or 3 case managers who are nurses who contacted me to say my company wants me to practice in 3 other states and I'm not licensed in those states, or I'm not licensed in 2 of those states, and they don't think I need to be. So you're still accountable to your Board of Nursing to do that. Now, many case managers do not wear one hat, right? We can't just have one hat. We're gonna do both case management and quality. And we're gonna do quality, case management, and UM. And it's very difficult to do all of those well when you've got so many hats that you're wearing. Okay, what are other kinds of inputs? What is the deal with the masks? It's like a lightning rod today. It's like you've got 2 big camps going on. One like, I shouldn't have to wear a mask because I space well. And the other says, you should wear a mask because you might breathe on me. And you got all this. But it is a societal pressure and factor that if you were working with COVID patients, that you would factor into your ethics, you know, what's happening with that. Now, we have legal and legislative influences. I actually had, this as a client that reported that, and that can happen. Ethically, that would, what if you had a client that said, I really faked depression so I could get Social Security disability, should you report them? Because one of our standards is that you do not support fraud. Actually I didn't have a client, but I had a neighbor who told me that he lost his job. He doesn't want to go look for another one. It's easier to get on disability. So he faked depression with his physician to get SSDI. Now, I'm sure all of you are giving a face right now like, oh, you know, and yet, do you report this? What do you do? Social media, oh my goodness. I have a very interesting case example, actually, to go to court also. With a social worker case manager, worked with a health plan. And she had a woman who had an assault. The woman and her husband had an assault from a gang, and she ended up with a traumatic brain injury. Her husband ended up with leg fractures. Okay, so he's on crutches. He was able to go outpatient, and she was admitted, of course. And then basically the social worker, one ethical issue is the social worker didn't even mention skilled rehab to her. She just said, you know what, I'm going to help you go home, and I'm going to refer home physical therapy, occupational therapy, and speech therapy for you. But she did not recommend or refer a home health aide. And her rationale was, they have money for this because she accessed a GoFundMe account that had been set up by the friends because she could not work, and nor could her husband. So this was their money to live on, but the social worker made the determination that she could use that GoFundMe money to hire a home health aide, even though she had a home health aide benefit with her health plan. So you can think Facebook, Twitter, where is this going? What can they find out about? And should you as a case manager do that kind of research? Is that ethical? Okay, this is, if you haven't heard John Banja speak, he's certainly been recognized as one of our prominent speakers on ethics and case management. His is his definition of conflict of interest. At what, you know, what degree are you influenced, basically, especially if you're having a fiduciary role and dealing with trying to help people with their finances. Friedrich Nietzsche has, again, this is an interesting, I love this quote because it says, convictions are more dangerous enemies of truth than lies. So you're convinced of something, careful with that. Okay, we're going to do a little quick, how's our time? Got a little time here, just a quick one here, and see if we can get some responses. This is a real case scenario. We'll talk and call her Barbara. She's a 66-year-old female, was recently diagnosed with metastatic breast cancer, had been in remission for 10 years. It had recently metastasized to the brain and bone, and symptoms were now stable. She had been treated in a SNF for pain management and rehab, and was now admitted to the hospital for confusion. The hospitalist feels that she is stable and ready for discharge. The case manager interviewed her sister, Mary, who was identified as the next of kin on the admission form. Mary wanted Barbara to be discharged home where she had previously lived for 25 years with her. Barbara was now bedbound. She needed assistance for all ADLs, IADLs, as well as meds. So a home-based plan was agreed upon. On the day of discharge, Mary disclosed she was not really a sister, but a close friend. And there was no healthcare or legal proxy. Does anyone want to jump in and say, ooh, what would I do? Doug, do we have any responses?
No, I don't see any right now.
Okay, we may be shy out there. Although this is a challenge. This is a real case, and it really was a challenge. It's one of my case managers that worked with me. And there was, you know, this was tough. It certainly could have gone to the court and tried to decide, you know, who's going to make the decision here. And actually what happened is very interesting. The hospital decided that they would slowly decrease her pain medication to see if she could become lucid enough to be able to give her input. And it worked. I couldn't believe it worked. They got her down to a point, she wasn't in terrible pain, but just enough where she could tell. And actually, Mary was not her sister, but a close friend, but was who she wanted as her healthcare proxy. So fortunately, it didn't have to go the court route. That doesn't always happen. But it presented with a lot of ethical challenges on this. Was it ethical for the hospital to decrease the pain medication? You know, was it ethical for the case manager to just accept Mary's as a proxy? I mean, there's lots of processes. Okay, let's talk about some facts. This is just, what do I do when I've got ethical decisions? Well, first of all, it's very important who's going to be affected by the decision. And then what are the issues? And that's not always easy to identify. Let's go ahead and find out who's affected, what are the issues, and what are the circumstances. And there we go. Consider how your own personal biases, we all have some, stresses, self-influence may influence your choice of action. Where is it that you may be bringing something into this that may affect this? Come up, what are the choices? What are the possible alternatives? You know, in no ethical dilemma, there's one answer. There are usually 1 or 2 or 3, and what seems to be the best, and see if you can get the team to be involved. Now, a lot of your organizations do have ethics committees, and that would be certainly a resource for that. If you've not heard Sister Carol Taylor speak, I just love her. She is just such an ethical person, and she loves case managers. And she's lectured actually at CMSNE conferences as well as elsewhere. And this is her guidance on approaching ethical dilemmas. First of all, know and follow your standards of practice. They are there to support you in their guidance. Educate others regarding your role. People do not understand the case manager's role. I know, how many of you have had your family say, well, you're not a nurse or a therapist anymore, are you? So even our family members don't always understand what we're doing. Try to educate them. I love this, humanize the job, make it human. Talk like what you do care, but show you care. Put your client first, always. Your client is first and foremost. Recognize and mediate do not run from conflict. We have to be conflict managers, otherwise nothing gets done if we let it go. Facilitate decisions, help make people, and always show you care, that you have the intellectual ability to understand what's going on, that you're willing to roll up your sleeves and help, that you have the imagination to think way outside the box, and that you're motivated to go down a different road. These are a list of resources, and these are kind of the key resources. Certainly we have others as well. And I think, Doug, we have a few minutes for questions if anyone has questions or comments.
Sandy, I did get one question when you were back talking about provider and workers' comp. And the question is, what if an injured worker still wants to treat, but the IME doctor puts the worker at MMI and claims doesn't want to pay for more treatment? What does the case manager advise the injured worker?
Oh, that kind of reminds me of the question, do you advise your client to get a lawyer? And this might be one of those situations. Do you? That certainly, you would be remiss not to mention that as a possibility, because they always have the right to do that. But is that the best? Again, that's one of those options. Certainly, this is one where, more documentation from the treating clinician, the physician, not the IME physician, but the treating physician, especially, hopefully they've seen the IME report and can respond to it, so that, maybe there's some, is that me?
It's okay. No, right.
Okay, maybe there's some things that came out in that report that the treating physician could refute or argue with or come up with more information, or may be willing to retest, reevaluate, try to see if the two will come, see if the information will go from one to the other. Of course, the case manager's in the middle. And is the case manager going to get okay from the claims adjuster to do this, to tell the client, this is what you can do. You can do this, you can do that, you can do this. There is a standard of practice that says you do not close a case, even if, let's just say she has to close a case because the claims manager says, I don't want you to do any of this. Then even then, she still has a duty to let the client know what resources they have. And I've still mentioned the resources that they have without making a decision. But that is a very tough situation. It happens. I've seen it. I share your dilemma because I've been there too. This is when I got talking about the claims managers and adjusters. If you don't line up with your same values and perceptions and so forth, this could go, unfortunately, with a lawyer, it get messy, and the claims adjuster is the one that's going to lose in the long run, but they don't always see it that way. I hope that answered the question.
Sandy, I have a couple more comments, and they have to do with your, and I will let you know, a lot of people, and just to acknowledge this, a lot of people are saying that your slides stopped advancing when you were on the payers slide. Mine were fine. Mine were fine, so I think the recording should be fine, but a lot of people have chimed in and said
Oh,
they weren't advancing.
oh, I'm
So,
sorry.
yeah, and there is a link to, just so everyone knows, there is a link
Okay.
to the slides
Okay.
in the
Oh,
invitation that you received.
oh,
I do have a question and a comment about your case study that you presented. One person said, there is no legal suggestion now, find a family member ASAP to help with the plan. Another person said, what does Barbara want? Is she deemed incompetent?
yeah. And that
And
last
there was
comment, oh, go ahead.
one other comment that said, how did she go through medical care at this level without a healthcare proxy acknowledged?
Oh, I love this comment. I love them, love them, love them. But first of all, how'd you get that far? They were, everyone prior to that was accepting Mary. And this case manager, as a social worker, said, wait a minute. Legally, I guess we could kind of skirt around that, but it isn't legal to do so. So that's a very interesting question. I'm sorry, what was the one before that, Doug?
There's no legal suggestion now. Find a family member as soon as possible to help with the plan.
And that was the problem. There was no family. Mary, the sister, quote, sister, that was the friend, said, there's no one else. I'm her support system. I'm willing to take care of her. We've been together for 25 years. So there was no other family. The only other, you have to go for guardianship or get to go to court to get a healthcare proxy.
Yeah, and I think, Sandy, in most states, I know it's true in New Hampshire, your healthcare proxy does not have to be a family member. It can be anyone
Right.
you designate. And in some states, including New Hampshire, we have a surrogacy law where if there is no one, no family member or friend appointed, we can appoint a surrogate without the patient's permission to make the
With
decision.
permission of the client, though?
Not necessarily.
No?
If we find someone who presents themselves as knowledgeable about the patient's needs and vested in the patient's best interest and steps up to be a decision maker, we can appoint them. It is temporary and it is limited.
Yeah, but in that case, that would have worked, I think, because I think Mary demonstrated she knew her, and there was enough history here that would have worked.
Right.
Again, state laws definitely will impact this.
Absolutely.
So good comments. So I love them.
Does anybody else have any questions or comments for Sandy? Type them in the Q&A box down at the bottom of your screen. We'll give it a minute or so. And just so everyone is clear, there is a link to Sandy's slides on the invitation that you got for this program. You can download her slides there. And also remember, at some point, this program will be offered as a recording through our website. And you'll be notified.
I'm so sorry about the slides because I saw them. You saw them.
I saw, mine were advancing fine. And yeah, but a lot of people did say that it was stuck on your payers slide, but mine looked fine. So.
Did they get copies? They probably didn't get copies like handouts or anything to
no, but they can download them.
Now they could, yeah. Oh.
All right, just a couple of things. I don't see any more questions coming up. Just so everyone is clear, if you haven't already received the link for your evaluation, you will receive that in the next day or so. Please complete that evaluation and send it back. That's the only way that you're going to get credit for this course. And remember, those certificates will not come out until the week of the 20th because of a little glitch that we had in getting the credits, but you will get the credit for that. And Sandy, I want to thank you very much. You're always wonderful to listen to, a font of knowledge that we look to. Thank you for your support of Case Management Society of New England over the many, many years. And we look forward to having you talk to us again in the future.
Well, thank you, Doug. And everybody have a good one.
Thanks for joining us.